to all of you. I warmly welcome everyone for today's CPD program organized by Government Medical Officers Association and Society for Health Research and Innovation. The webinar link will be open to you until 10 a.m. and no late attendees will be entertained thereafter. Each attendee should attend till the end of the webinar to obtain e-certificate for participation. You will be given CPD points which are strictly adhered to NCCPD guidelines, but apart from CPD points, you will be given the e-certificate for participation. The link for applying the certificate will be sent to the chat box at the end of the webinar. The chat box will be open to you for your queries and they will be discussed at the end of the session. Also, we kindly ask you to mute your microphones and switch off the video to avoid any interruption during the session. So now let me introduce Dr. Himalosa Kalambarachi, Acting Consultant Physician, to introduce today's speaker. This is over to you, sir.
Good morning, everyone. Thank you, Dr. Sachini. Welcome to today's GMO Shri webinar series. I'll be grateful to you. You're joining us with very difficult time. There will be a connection issues and electricity issues, and please stay with us. And we will be back in very soon. Today, our resource person is Dr. Anuruddha Padiniya, who is a consultant pediatric neurologist at Lake Ridgeway Hospital. And he's not very strange person to you, and we all know about him. And he has worked as academic head of Department of Pediatrics in Faculty of Medicine, University of Rajarata for 8 years. And he's a current president of GMOA from 2011. And he has honored with prestigious leadership award called Eisenhower Fellowship in 2012. And he has done various publications beyond the level of medicine as well. So without further delay, I would like to invite Dr. Anuruddha Padiniya to give his talk. And please stay with us. Please stay with our housekeeping messages. Sir, session is over to you.
Good morning to all of you all. Today, the lecture which is given to me is to talk about the childhood epilepsy. Now, the topic I have slightly changed. You might see on top there, we are going to talk about how to develop a care plan for childhood epilepsy. Now, simply why I did that is when a patient comes for treatment, patient is the child who is coming with epilepsy. We have three people are having trouble. One is the doctor with regard to the diagnosis of epilepsy and to institute the management appropriately. Secondly, the child has a problem, maybe not what we want him to do. He has his own problems. And then the mother who accompanies or who is the caretaker will have different sets of problems. But ultimately, that our all focus should be how well that we are looking after this child. So to do that, it is very important that we have a mechanism that to develop a care plan for a child. So rather than talking about the approach to epilepsy, I thought it is a better approach to develop a care plan for a child. I think that can be applicable to any other discipline as well. Now, how we are doing during this lecture, basically, we are intent to look after these three aspects. Number one, just to visit the current status of childhood epilepsy management. Rather than the management, today I'm going to confine this 45 minutes to the diagnosis of the epilepsy, which is the first part of the management. And then on a later date, we'll discuss about the management. Otherwise, it's too big for an epilepsy lecture to do in 45 minutes, all these areas. Secondly, to understand how well that we can diagnose with the current evidence available, and we call it a complete diagnosis of childhood epilepsy. So from current status, how well we can upgrade ourselves to do a complete diagnosis is what we are aiming at. So the intention of the lecture is to train you all or to give you an insight how to go towards a complete diagnosis from what we are doing at the moment. Now, what I am going to use in this lecture is the basic principles of this ILAE, that is the International League Against Epilepsy, which we are the guiding arm of this epilepsy in the world, including the child epilepsy. They have proposed this 5-axis diagnosis of child epilepsy, which basically leads to a complete diagnosis of epilepsy to institute a better management from the patient point of view, or to come down to the care plan, what I've been telling at the very beginning. So currently, if you see a diagnosis card, this is from a Premier Hospital of Sri Lanka, you can see that we put the diagnosis as seizure disorder. Just to tell you how primitive we are, now telling that this is a seizure disorder is just we are going beyond that. This is a paroxysmal event. Now even migraine is a paroxysmal event. You can have hypoglycemia as paroxysmal events. So likewise, now we are just at the bottom just to say it is seizure disorder. That has no meaning from patient point of view with regard to a care plan of a child. It is so primitive. So what we are trying to aim at is to bring it up to a complete diagnosis, or the 5-axis diagnosis. This is actually from my book. You might have seen my clinic book I am conducting for last more than 10 years. And I have a clinic book. In the clinic book, rather than just putting seizure disorder, if you see the contents of the book, there's a page 5 actually, every book, to put this information to be documented in favor of developing a care plan for the child. So you can see, number 1 is, you can see there is a description rather than just saying a seizure disorder, what kind of events took place and how it had brought up to this level. Then the second line, you can see whether we want to verify whether they are in the territory of epilepsy, or whether we are dealing with non-epileptic conditions as epilepsy, which might do more harm than doing betterment for the child. Thirdly, you can see we have come down to a level to identify the seizure type very clearly, and then epilepsy syndromic diagnosis. Here what we say is absent seizures. It was the presentation, and we have confirmed that, and we have concluded that the child has childhood absence epilepsy. But we haven't stopped at that point, and we have gone down to see how the intelligence is of the child. And here is the IQ of 127 was marked by a team who are working with me, basically quantifying their IQ. And not only that, they go into the other territories of education and see what levels of issues they have linked up with. Then with regard to behavior, we might ask from the parents, we might get a report from the teachers, or we do our clinical observations, or we might lead this patient to a referral to psychiatry or psychological teams, and then we might conclude what the behavioral issues are. Then the education, because from a child point of view, most important productivity builds up on education. And education includes not only the academic activities, also the extracurricular activities. So you can see it's much more comprehensive when we are going to do with this 5-axis approach, where rather than just confining up to a very primitive level of calling it a seizure disorder. So that terminology had to be given up, and we have to build it up to this level. So basically, this 40 minutes I am going to touch with you all is to educate you all, or to capacity build in you, how you can move from this left to right move. So let's begin how we are going to do that. Now, to be fair by the child, developing a care plan, and in the best settings, they say in even a nice guidelines, they say with the pediatric neurologist and very qualified pediatricians, the epilepsy diagnosis is not 100% correct. Unlike the other fields, we have gap of at least 1 in 4 is wrongly diagnosed as epilepsy. So we are treating, sometimes we are instituting various pharmacological interventions, and ultimately we are doing more harm than betterment from that point of view. So therefore, it is very important to understand that whether we are in the territory of epilepsy or not, because several reasons. There are very difficulties or limitations of gathering information. Like say, we are taking history not from the patient, we ask the recollection of the patient's parents, so the third party narration. So therefore, there are limitations of the information. Even if you have upgraded recently, everybody carries a phone. Because of that, everybody has a mobile phone, so they do videos. Despite academic team which sit together, not only the pediatricians, pediatric neurologists, then electrophysiologists, all of us sometimes when we were trained there sit together and see the video, but still sometimes it's difficult for us to conclude very confidently whether it is seizure or not. So that limitations are there. And the other point is, unlike ECG, EEG sensitivity is not 100%. It is less than 70% all the time. So because of that, the sensitivity of the EEG will be a problem. Apart from the absence seizures and certain types of epilepsies, it is more helpful. Most of the time, say frontal lobe epilepsies and various other epilepsies, and especially in the pediatric practice, the sensitivity of the EEG is not 100%, is lower than that. And because of that, we have limitations of EEG support. It's only a supporting element, not a kind of a very complementary. Because ECG, of course, if there's inferior MI, you can't deny that fact. The patient should have an inferior MI because the entire heart works together. But the EEG, it's a summation of electrical activity, what we are reading through leads on top of the scalp we are recording. And ultimately, the sensitivity is low. And but during the recent past, these videos have helped us in a better way. And there is a saying in the epilepsy field that it's better delay the epilepsy treatment than starting medication based on a wrong diagnosis. So therefore, we have to weigh the benefit versus the risk versus the benefit when you are going to manage to be fair by a child. Now, having said that, the contents of this lecture, as I told you, to navigate you all from the seizure disorder or the paroxysmal disorder up to a level of 5-axis diagnosis, how I am going to take you through is the first, and this is, as I said, it's the first volume because the management aspects will be dealt later on. So first of all, you should have an idea what is a seizure. There are various definitions, American definitions and then UK definitions, and we'll go into that. Then how confident we are with regard to a seizure, how we are going to confirm that it is an epileptic seizure that leads to epilepsy. Then how we are going to confirm that you have epilepsy. Now, once you have epilepsy, current practice is we have to qualify it to epileptic syndromic diagnosis. So it is beyond, it's not one category epilepsy. We have to qualify it to a typical category. Then once you do that, you have to identify the associations which goes hand in hand with the so-called epilepsy syndrome. So therefore, when you put these lines together, you can call it that we have reached an epilepsy complete diagnosis. So it's fair by the child because we have understood the problem in the child, and therefore we will be able to develop interventions, and then we can forecast their prognosis based on the epilepsy complete diagnosis, and we can develop a care plan accordingly. Now, the first topic is whether all seizures are epileptic. Now, what is the definition of epileptic seizure? Now, usually there had been a debate, and ultimately it was concluded as a transient clinical event is a seizure. But nowadays, basically seizure and epileptic seizure, there is a bit of a understanding issue. But if it is going to be epileptic seizure, and it had to be linked up with abnormal and excessive activity of the synchronized population of cerebral neurons. That means the clinical activity, or we call it the transient or paroxysmal clinical activity, had got to do with the cerebral neuron, something got to do with the brain. Now, if you get an electrocution and if your body parts are moving in a transient manner, that doesn't mean that your brain is not involved here. It's not epileptic seizure. So something got to do with the central neuronal mechanism, or you call it the brain, to call it epileptic seizure. Then what is the definition of epilepsy? That controversy comes. It is recurrent epileptic seizures. So going by the definition, to call it recurrent, at least you should have 2 seizures. But with one seizure, are we going to start treatment? That's a debate all over the world. There are enough publications, lot of reviews. We have done enough journal clubs on this. How either way we are going to do. But however it is, the basic diagnosis of epilepsy is recurrent epileptic seizures. So at least you should have two to qualify to that level. But very importantly, what I want to tell is all seizures are not epilepsy. This is a very important point. It had to got to do with the brain neurons to call it epileptic seizure for us to bring it under this care plan of child with epilepsy. Now, therefore, the first thing what we need to do is we have to verify whether it is epileptic or not. It is crucial. If you fail to do so, the entire line of work will be wrong, and we will be instituting wrong management, wrong interventions, and that will have more harm than betterment to this child. So how are you going to say whether epileptic or not? This is one of the major things what I always ask my registrars to do, that to learn about the event analysis. The least attention is paid for event analysis. The doctors, not only Sri Lankan doctors, all over the world, and for that matter, most of the professionals, they have deficiency in their listening skills with regard to their communication. They don't listen to the patient. And according to the literature, they say no professional will, or every professional, usually the professionals will interrupt at less than 12 seconds when somebody is going to, a client is going to talk to you, in this case, the patient. So it is very important. The event analysis is simply by listening to the patient. And I told you there are deficiencies. The patient can't recollect what happened. Actually, we are getting a third party narration, but still we will be able to put both these information together. Plus we can add it up with this videos, and we can come up to this territory. Now, in the event analysis, to do in an objective manner, there are areas to touch. We call it pre-ictal. That pre-ictal means just before the event, what happened. That is very crucial. Then you come up to the ictal phase, or which means the what happened during the actual event. Then the post-ictal. So these are three areas that we need to analyze. So we have to analyze all these three areas. Now, for other important reasons, even the ictal part can be divided into three. So there are 5 areas: the pre-ictal phase, and early ictal phase, mid-ictal phase, late ictal phase, and the post-ictal phase. Usually, if you put all these 5 areas analytically of the event which was described by the patient, possibly we will be able to do a better job and develop a care plan much more confidently. We can conclude either we are in the territory of epilepsy or not. So as I can tell you, you can have these 5 areas analyzed and documented even in the book, and then it's more precise manner of managing an epileptic child. And out of these areas, what is the most important area? Ictal and post-ictal. Yeah. They say what we want to see is whether it is a provoke event or not. So to do that, most important area is the pre-ictal area. In the pre-ictal area, we can see under one context the patient got this so-called event. We can say a child was standing in a school assembly and for a long time, and then all this sequence. So therefore, the context of the child, how he worked, is important. Then the premonitory signs, like say what happened just before. And unless you ask, the patient won't tell you. The secondary generalization of the seizure, the generalized part will be seen by everybody, but the secondary generalization, the early starting elements will not be touched unless you really ask or verify in a serious manner. And sometimes when you tell these events and when you ask these questions, when they get the event for the recurrence of this event, then they might give a more precise information to us because they know the value of that information. And then whether there had been any provoking elements or triggers, and all these things come under pre-ictal area. And I don't say that the other 4 areas are not important, but these will basically give us whether it's a provoke or not, epileptic or not. That clarity will be basically value added with this information given to us. So by doing that, what you need to do is you have to exclude the non-epileptic event. That is the next part, because you have to screen the epilepsy part into your camp, and you have to exclude the non-epileptic part. That again comes under neurology most of the time. But we have to know that we are dealing with non-epileptic events. As I told you, EEG also will be limited. So this clinical work and listening to the patient is so important. So what are the non-epileptic events? Just to list, because that is not the topic what we are going to talk here. That lecture I'll give in later, possibly. And non-epileptic events, you know, various types of non-epileptic events are there. So we have to learn every aspect of it. There are a lot of reviews gone into the non-epileptic event. There are some neurologists who only study the non-epileptic events because that is that crucial, and management is also vary according to the non-epileptic events. So you can see we can classify into various camps. Now, just to highlight to how many non-epileptic events are there, I have devoted my next set of slides to do that. Now, I have listed here the syncope. I am going to use this syncope as an example to use in the event analysis for you to enlighten you how efficiently that you can divide whether it is epileptic or not, the activity to be done in how better. Now you see, now if I put this the same algorithm, if I am going to use, now in a syncope, you will see in the first phase or the pre-ictal phase, there will be events like, say, vision might get affected and they might feel dizzy, and there may be autonomic features like palo, flushing, and various vomit, nausea. All these things will be felt in a syncope at the pre-ictal level. Then going into the early ictal phase, there will be certain other clinical features they will come up with, and visual and other dream-like experience. They will start falling sometimes. Then at the mid, they might completely fall, and unless somebody holds him on, and then there can be events depending on how we are going to intervene with that child. Then late, there may be a seizure. So if you don't qualify the first three parts, they might come out with this fourth part saying that this child had seizure. Yes, child had seizure, but it's not an epileptic seizure. It is because of this vasovagal syncope or reflex seizure, which is due to another system, not the neurology system. The supportive system to neurology system is in trouble, that is the heart and the supply. And because of that, child is getting seizure, and this is not originated from the neurons itself. So therefore, it is not an epileptic seizure, but it's a reflex anoxic seizure. And the post-ictal events may confuse sometimes for us. It can be depending on whether you have gone to a seizure or not, epileptic seizure or not. It varies the post-ictal events. So when you can see how better that we can analyze vasovagal syncope under these 5 headings, and how much information in favor of the child academically that we can put in place in order to diagnose or to verify whether we are in the territory of epilepsy or we are out of epilepsy territory. That is very crucial. I am not going to analyze each and every topic. I have given this as an example. The day I am going to do a lecture on the non-epileptic events, we will analyze every non-epileptic events with videos like this, and then you will be able to master to differentiate epileptic event from a non-epileptic event to qualify it a epileptic seizure before EEGs. This is clinically still. So when you talk about the syncope, you can see the list of non-epileptic events I have listed: the vasovagal syncope, reflex anoxic seizures, breath holding attacks. Breath holding, actually pallid attacks go in favor of more syncope. It's the asystole what causes the pallid attack. This is not a cyanotic attack. Then the hyperventilation syncope, convulsive valsalva, neurological syncope, and there can be airway linked up with some syncopes, orthostatic intolerance. Then you can have arrhythmias leading to syncopes and hypertonic spells in various conditions. And all these things are non-epileptic events, which might ultimately, unless we analyze, think that it is a seizure, and we might wrongly treat. And if you list the behavioral and the psychiatric disorders, the daydreaming, inattention, every topic has a list to talk, actually, self-gratification and various other psychological, behavioral, and psychiatric disorders that you need to understand. And these psychiatric disorders, there are some neurologists who have analyzed these non-epileptic seizures to a great extent, and they have analyzed the features of a non-epileptic psychiatric event. And based on that also, they positively diagnose sometimes it is a non-epileptic event. Sleep-related issues also sometimes get blended up. You can see various types of REM and non-REM sleep. Sleep, again, another neurology topic. We'll do a lecture later on. And sleep is very rarely touched by most of our clinicians. That is 1/3 of our time is spent on sleep. If you are going to talk about the quality of a person, quality of life, it's very important that you address the sleep, but it had been neglected in a big way all over the world. I think it is time for us to try that also in the latter topic. But you can see various types of sleep-related conditions are coming under the non-epileptic events, and unless we know those things, we might think that that is a seizure during the night. There are seizures which can come up in the night, like this Rolandic epilepsies, frontal lobe epilepsies, but the differentiation is not that easy sometimes unless you have gone through in detail into these kind of non-epileptic events. Then there are other paroxysmal events, like, say, even I have not listed this migralepsy is another entity. They talk about the tics, then the Tourette syndrome, the stereotypies, and various kinesogenic dyskinesias and non-kinesogenic exercise-induced various activities, and various types of torticollis, ataxias, and all these things are we have to thorough before you qualify it to epileptic seizure. Then the migraine, or the headache-related migraine with visual aura and hemiplegic migraine, benign paroxysmal torticollis and vertigo. This benign paroxysmal vertigo is most of the clinicians, they treat as focal epilepsy with carbamazepine and without listening to the patient. The patient usually gives a very classic history of benign paroxysmal vertigo, and over my 10 years, I have never seen any clinician diagnosing benign paroxysmal vertigo. All are on carbamazepine by the time they were referred to me, and I usually stop the treatment with carbamazepine and ask to drink a lot of water, and that itself is curing them in majority of the benign paroxysmal vertigo. And by adding carbamazepine, that is not going to be helpful, and they might add the second drug, third drug. And unless you exclude these non-epileptic events, what will happen is you might add medications, and that is not going to work. Then you add the second drug, third drug, and what will happen is then they give a picture of refractory epilepsy easily, because the drug is not going to work, and ultimately patient looks like a refractory epilepsy child, and we basically had done the worst thing to this child without developing a proper care plan. I have stopped medications on such patients, and some patients who are in special schools are going back to the normal school after stopping medications and treating appropriately this non-epileptic event. So therefore, it is very important that you need not to rush to start treatment. Rather than, it is better you verify those conditions, asking them to bring a video, asking from others, verifying it whether it is non-epileptic events for the best interest of the patients, and to develop a care plan for the child. And there are certain other conditions, non-epileptic. Now you can see how many non-epileptic events I have listed here, about more than 25 non-epileptic events. So I think all these things need to be clearly known before you go to the territory of epilepsy, because each and every these non-epileptic conditions has their own way of managing a child. Right, having said this non-epileptic conditions, say you are confident and you are comfortable to exclude all the non-epileptic conditions and manage them appropriately. Now you are very confident that you are now in the territory of epileptic seizure, not a non-epileptic event. Now coming down to that, you have to confirm whether it is an epileptic seizure. Now how we are going to confirm that? Now that is actually, now we are only entering into the epilepsy care plan, because otherwise it's a non-epileptic care plans what we have to develop. So therefore, the next step is what kind of seizure. I will tell later why the identifying what type of seizure is such important. So what kind of seizure is the next thing. Now ILEA in 1981 developed a seizure classification for the best interest of entire world. And you can see it is how many years? Only 40 years ago. So therefore, neurology, epilepsy, epileptology work is, somebody can claim that it's very primitive, only 4 decades work worldwide. So therefore, we might have handled these conditions in a very primitive manner up to now. So therefore, we have to institute the latest activities, and we have to be careful about our management. So the ILEA 1989 seizure classification will be like this. This must be known to you all. You know the simple generalized seizures and then the partial or seizures. Therefore, now partial, or now this partial word is now not that much used. It's more focal seizures. That is how they call it. And you are familiar with this absence seizures, which is a non-convulsive seizure. Seizures always need not to be convulsive. Then you have the tonic seizures, the clonic seizures. When tonic comes together, so first part is tonic and then the clonic, you call it a generalized tonic-clonic seizure. Then you have the myoclonic. When the myo part is much more and will be thrown away, you call it a myoclonic seizure. And then you have the atonic seizures, or where you collapse by losing the tone of the body. Then the other simple and the complex partial seizure, that is how the ILEA classification 1981 concluded. There had been development. So it is better that we have just a look into what these seizures are to these videos of a tonic seizure. Now, tonic seizure, there are no sounds here, just see, and I have listed the key features on the right hand side of the slide itself. Now just see this video. So generalized tonic seizure is, you can see this patient has gone into a tonic seizure. It can last for shorter period, usually not during the sleep. And it's a generalized seizure, so child is unaware or loss of consciousness should be there attached with. So that is a tonic seizure. It's just child is increasing the tone and losing consciousness. Then a clonic seizure, you can see the clonic activity. It's moving, shaking, like people call it shaking. It is, the shaking is different to tremor. You can see the oscillation, the frequency is much coarse than the oscillation of a tremor, which is much more fine actually. It's clonic seizure. Then generalized tonic-clonic seizure. We'll see that. So the first part will be tonic, and then they go into clonic phase. These videos I shared from the ILEA. They are now going into the clonic phase. Initially it was tonic and now clonic. So we call it tonic-clonic seizure. You can see it is sleep monitoring. Mother is ringing the, adjusting the mother, or the caretaker is adjusting the bed. Possibly long-term video ED monitoring unit. So the central, it is monitored by the epilepsy nurses. They will rush here with the EEG technician sometimes. Then the myoclonic seizure, it's very difficult to catch, but we'll see. Yeah, it's myoclonic. The muscle activity has a role to play. So myoclonic, it's very difficult to catch myoclonic seizures for the obvious reasons. Atonic seizures, you call them drop attacks usually, and you can see the video EEG synchronized. You can see the event is synchronized video EEG here. So that is why you can see here. There, it's drop attacks. So there, it's the drop attack, and if child was standing, well, will fall. So otherwise, he's only dropping the head. So you can see now. I told you these are events. Through event analysis, we excluded all the non-epileptic events. Now came to the epileptic seizure territory, and now we have verified what kind of seizure is it. Now this is another you must be familiar with. Now you are going for hyperventilation, obviously, to see the typical absence seizures. We'll see what happens doing hyperventilation. So in the pediatric practice, you give a fan for them to blow. Yeah, it's abrupt onset. There are some myoclonic elements on the eye or sometimes in the hands also that sometimes, and then you call it a myoclonic absence. And now the child was basically staring for a while. She doesn't know what happened. And suddenly, and then the recovery was sudden, no post-ictal drowsiness or anything. So that is called absence seizures. No basically jerks, basically stand still. And if you have a pen or other material on the hand that didn't get dropped, even the fan she's still keeping in her hand. So basically they are just staring without much losing the tone, and they are called the absence seizures. Now you can see atonic seizures I showed you. So I think now we are slowly entering into the proper epileptic activity of a child. Now the purpose of seizure classification and syndromic classification, somebody might ask why we are doing that. For the simple reason, obviously, that will simplify what we are doing, and it is easy rather than using a long narration. We have seen in the diagnosis card, they are writing the entire narration. We call it a semiology in our practice. What happened, that is important to some extent when you can't verify whether it is what type of a seizure. It is better if you are not confident to write it down, but if you are very confident to bring it under a territory, then you can say this is this kind of seizure, and this will be easy and simplify the communication. It is important. Then it will give a therapeutic guidance. Very importantly, the seizure type will decide the medication usually. If there are myoclonic seizures, you might start clonazepam. Basically, the syndrome will decide the duration and the prognosis, and the seizure will decide what kind of medications and intervention that you are going to adapt. So it's very important therapeutic guidance, and the prognosis based on the evidence also can be to some extent verified on the seizure classification. Now we have gone up to that territory, but there can be confusing stuff. You can see this generalized and partial, various classifications are made, and this is the exact content I have been telling you all, but this is how the ILEA used to put this kind of information in boxes. Now again, after 8 years of seizure classification, they could classify, ILEA could classify the epilepsies. It is 1989 classification. Now, what are the epilepsy classifications? So this is how they classified. They said the localized related, and then generalized, then intermediate where they couldn't conclude where it is, then special syndromes. Can you make anything out of this kind of classification? Actually, they consider this kind of classification as a failure by the ILEA, because you get confused you get confused with this kind of classification. So therefore, you need not to get, we will simplify our care plan process without going into this kind of territories. So therefore, ILEA 1989 brought the epilepsy syndromic diagnosis in this manner. And this is actually, I want to emphasize you a fact. Now, so far you might have an intention that epilepsy is only one entity. And seizure disorder, of course, it's more raw than that. But now you can see from 1989, the epilepsy became epilepsies. If you say the benign Rolandic epilepsy is, we expect it to be benign, but you can see Ohtahara syndrome is deadly. So therefore, it is not one entity. It is true that everything starts on the base on epileptic seizure and the definitions, but when it is going to be a care plan for the patient, we are in different territories. So therefore, no more epilepsy. It is the epilepsies that we have to aim at in the process of diagnosis in our patients. So, and very importantly, the syndrome, if I ask what is a syndrome, you might say it's a collection of signs and symptoms, or you might say it's a collection of clinical features. But epileptic syndromes are electroclinical diagnosis. So therefore, on top of clinical work, you have to bring the EEG. Now you can see where the EEG will come into place with regard to the diagnosis. My research actually in Oxford was basically to see how the clinical diagnosis of absent seizures have gone wrong with regard to the electroclinical diagnosis, and it was proven that the 67% of the diagnosis of epilepsies only on the basis of the clinical diagnosis on absent seizures were wrong. And when you put the electro part or electroclinical part, the total comprehensive diagnosis principles, and we can improve the diagnosis. Actually, it was published in the archives, and it was read in the archives editorial with that point. So therefore, it is important for us to have an electroclinical diagnosis. And on top of that, Ilea brought the 5-axis principles of diagnosis in 2001. And based on that, what I have been telling you all was lumped together like this. Now, 5-axis is the axis 1 is the description of the semiology or the narration. I told you already. Now you know that. Axis 2 is the define the epileptic seizure type. That is also now you are confident with. Now, the third line is once you do all these 2 steps, you can define epileptic syndrome, but you have to bring EEG, ideally digital EEG evidence build up into our clinical knowledge, and then you will be able to make it what kind of epilepsy or what kind of out of epilepsies define syndromes. Now, what are the 2 other axes that you need to learn? The axis 4 is, if possible, to identify a etiology. Why I say if possible, I will verify it later, because all the time we can't go for an etiology-based management. Basically, we manage with evidence-based management. We are not privileged enough to manage etiology-based in the most of the time in epilepsy. Then it is not going to end that. The 5th axis of another important aspect is the identifying the epilepsy-related other impairments for a better care plan, or to have a tailor-made care plan for the child, because in the educational age. Why I am saying so is very importantly, child is in the education at the moment, and most of these epilepsies they will recover them from. But by the time, if you don't consider their educational aspects and their behavioral aspects, and we are just going for the seizure eradication or termination of seizures, or to have the complete seizure control, disregarding or compromising their education, by the time they recover from the epilepsy, they will be cornered in the class, and ultimately they lose their education through that. So therefore, it is very important this all 5 axes are to be considered together and to develop a care plan appropriately. So let us see in detail what is axis 1. So it's a description of semiology. I went into tell you all how the event analysis is going to be helpful. So you, with the mindset of event analysis, we have to listen to the description or the narration to list various signs and symptoms which can be classified in the phases of this event analysis for you to confidently diagnose whether it is what kind of event it is, whether epileptic or non-epileptic. The second axis is defining seizure types. I have gone through that, and the various types of seizures. Then the third axis is the define the epilepsy syndrome. That part we have to go through. Still haven't touched that. And I emphasize the fact it's an electroclinical diagnosis. So therefore, it's still in the phase of evidence-based management. Evidence means we are not managing in the etiology-based management. So therefore, I would like to use a couple of slides to emphasize you all on what is the digital EEG technology is. And I'm not going to details, but just to touch, this is the digital video EEG machine. You can see, unlike those days, it's a very simple machine, digitalized, that recently happened in the EEG technology. You have ability to record more than now when you basically a human eye can't see more than 16 leads in given time, but ability with the digital EEG, you can record even up to 32 leads by a computer, and we can see as appropriately various leads. But unfortunately, in the pediatric practice, the skull size is small. Because of that, you can't pick the leads, 32 leads sometimes, because the skull is small. Because if the leads are much closer, their gel will get connected, and ultimately there won't be voltage difference in the this thing, and that will come as a flat recording. Ultimately, you will not be able to get any information out of it, and people might think that there is SOL or there may be a severe encephalopathy because of these technical reasons. However, digital technology EEG is the order of the day today. EEG we will discuss under the management later on, and it can be centrally coordinated. This is the EEG department in the Ridgeway. Entirely it was a donation because of my connections in the American Pediatric Neurology Association. They collected funds to donate 6 machines. This is the man who led that, Dr. Warren, the pediatric neurologist, and our DG, who was the chief guest at the inauguration. This is latest machine. These are things that the information we can gather from the digital EEG, unlike the paper EEGs with a lot of disadvantage in the time. And the paper EEGs, of course, taking a lot of space, and it can be in the record room and keeping those records for long. All these deficiencies are being eliminated by digital recording, and you can compress them. The recording, say if there's a 7-day recording, you can compress them and see whether there had been events, all these facilities, and that can be correlated with the video, that can be correlated with the synchronized imaging activities, and you can do various other technological collaborations with this digital EEG technology at the moment. So, and it is low cost because there are no paper cost on that. And then an interesting thing to tell is when I went to cover up Candy as well, there was a complete room left to record room with paper EEGs, and ultimately what we did was I cleared all these paper EEGs and converted it to a digital EEG, and ultimately the current EEG technician's restroom is that record room in Candy. So you can take the longer duration recordings, and you can use various montages or various views to see that, and real-time synchronizing videos. These are benefits of digital EEGs. So all these efforts are done simply to build it up to the electroclinical diagnosis. So why do we use a syndromic based classification? Now you must be clear why we are using it. And now we come to the axis 4, that is that identifying a cause. Now the reason is from the evidence-based management, if we can build it up to a etiology-based management, that will be value-adding our activities. So that is to build up the etiology-based, if possible. Why I say if possible is most of the time the cause is not clear, and even if the cause is clear, we are not very confident to say. That is why the current, these are the figures from international literature. With all this technology, still most of the epilepsies, we don't know the cause, and that is the first sentence in the ILEA. Most of their patient guidelines they start with. So investigation, I'm not going into detail, that will come under the management, but I told you something about the EEGs, video synchronized digital EEGs, and then some we couple it up with the imaging, some blood investigation, genetic workups, and other things are listed. And now we are still in the territory of epilepsy. We haven't gone into the association. So how to treat epileptic seizures is just to touch the various interventions possible. You might avoid the provoking factor. That itself might give us clues to how you are going to manage this patient. And there are medications or pharma to manage these patients, then the ketogenic diet, then vagus nerve stimulation you may not be that familiar with. You put a, like you, the cardiac facing, you give a vagus nerve facing, and through that people are trying to, there had been attempts to make the epilepsy some control. We are not that practicing here, but we have experience using them. Then the epilepsy surgeries is the another step. Now, having said this up to the fourth axis, we'll link up to the fifth axis, that is to identify the areas that you need to touch. I usually call it IBE, that is intelligence, behavior, and education. So that will ultimately build up a tailor-made care plan for the child. Now, how we are going to do that? You can see this is the education. We usually do the learning assessment by our team. You can see on the top of the area, you can see their IQ is being measured, and IQ 118 of this child, and ultimately according to the IQ we might quantify their, extrapolate their age. Now this child is equivalent age is 15 years, but the real chronological age of this child is 12 years, and but because of the IQ, their abilities are higher than that. You can see, then you go into the details of it, the attention span, then the underlying understanding the test context, then the format, the energy levels, attitude of learning, like that. By using various PhD developed tools we use to analyze these patients. Then you go to the second part of it, you can see that detail, the attention, memory, short-term, long-term, visual abilities, their reading abilities, coping abilities, all these things are measured in our clinics, and ultimately then we come up to a detailed analysis of their learning abilities. Or in Sri Lanka or in the world, currently learning difficulties are being taken care of, not the abilities basically, but at least the difficulties are being mapped into this kind of chart, and this will be used by the patient and the parents, and not only that, the teachers and the clinicians, then the clinical psychologists, educational psychologists, the whole team will blend the epilepsy with these impairments. Or now in this case, you can see his IQ is higher, but you can understand their attention is low. So unless you, now this child will appear as a normal child with this subtle deficiency. So unless you address that subtle deficiency, the child will be at a significant disadvantage. Now, if we have a child with lack of vision, everybody will detect that. If we have somebody who can't hear well, everybody will detect. These are actually neurocognitive deficiencies. Nobody will detect, and they're expected to be in the normal track, and ultimately they will struggle because of this deficiency. Given attention to this special educational needs, definitely they will show their colors compatible with this IQ. So this is why when you are going to develop a care plan, you can't only look into the epileptic aspect, but also the other aspects as well. Now you can see the IQ and the extrapolated age, the mental age, and then the other deficiencies. You all had to be governed appropriately, and the child is above average, but unfortunately child has a attention deficit. So that had to be dealt with. We have to develop an intervention to support that. So these are actually recommendations coming after that. The clinical psychologists will sit with the teachers or the educational psychologists, and including ourselves as clinicians, and we give a care plan. We don't have much facilities in the setup apart from some private schools. We get we capacity building their parents to do the better thing to the child. So I think having said that, now we have touched all 5 areas. I think we have come to the fairly end of this lecture. Just to recapitulate, and ILEA revised their terminology and the concept in 2010, and there are new classification brought in, but still we are struggling to basically make it much more lucrative. Now, just to keep your memory, to give a mnemonic, the practical approach is being developed. Wonderful practical approach is developed by the British Pediatric Neurology Association. They call describe with double S, and the same 5 axes are developed like this. The description of the event or an epileptic or not comes under event axis 1, then the seizure type and the syndrome, then the cause or the axis 4, and then the relevant other associations. So it is described a wonderful mnemonic developed by the British Pediatric Neurology Association for the best interest of the patients, and that can be your take-home message for you to ultimately develop a care plan for a child with epilepsy. The last 5 minutes I have come to, so let me put this in this way. So the axis 1, description and the epileptic or epileptic care or not had to be. So very important axis 1, where all other 4 axes will decide on the axis 1. If it is non-epileptic, out, because that doesn't come under this territory. It's the management is different. But epilepsy entry point is axis 1. You have to decide, very important, whether you are going to axis 2 or not. So very important, listening to the patient, making your all efforts to decide whether you are in the territory of epilepsy. And once you do that, you come to the axis 2, then you classify the what type of seizure based on evidence, and then that will decide what is the medication that you are going to give, and then you come to the syndrome in axis 3, and again duration and the prognosis can be built up to that. Then this is actually recapitulating the entire lecture into one slide, and then the cause or axis 4, and then etiology based management opportunity will be come up, and after that you come to the 5 axis, and their intelligence will be measured, their behavior had to be assessed, and then the education appropriately and your interventions or the care plans in a comprehensive manner can be developed based on this. So we can call it a tailor-made care plan for the individual child concerned for the best interest of the child. So we have to decide, when you are going to do these interventions, the quality of life or the productivity, in this case the child's education, whether we are going to take this child through the normal sequence of events or whether we are going to do the iatrogenic sequence of events. Sometimes the iatrogenic sequence of events is not good as normal sequence events. So that had to be, you have to have a collaboration with the parents, we have to have a collaboration of the child, and sit together and decide what kind of activities, care plan that you are going to institute. You can't do on your own, and you can't just dictate various medications on top of your ideas to the patient and to completely forget the rest. And when you are going to give especially the sleep medication and other things, you have to be careful not to give in the morning dose. For a child who is brilliant in his schoolwork, had to be night. So not only the medication, how the intervention needs to be developed and what doses we are going to use, all these things, because you are deciding upon someone else's life. It is ultimately his intelligence, behavior, education, all will affect unless you give a careful attention to all these areas. So the benefit of the epilepsy complete diagnosis, obviously now you might be able to compile together. It is more tailor-made, and it is better prognostic comments, and it is, we are collaboratively doing that. It's all other aspects are being addressed, and the child's potentials are being recognized and attended, and the parents' contributions are built it up to that, and it ideally gives a better outcome, and there are a lot of patient satisfaction. Not only that, the clinicians also will be very happy at the end of the day when the child is doing very well. I have children who are on 3 or 2 medications and ultimately got 191 at their scholarship exam, and all these beauties we can enjoy provided we manage this child as our own child by addressing all these things. Just to the final 1 minute to use just to highlight the common pediatric epilepsy syndrome, just to list them down, because talking about the common pediatric epilepsy syndromes itself is a complete lecture, even more than 1 lecture, but just to list them. Now, having said all these things, the epilepsy syndromes, if you are going to learn from top to bottom, it's very difficult. So what ILEA has done is they have classified according to the age. Now, what comes on the neonatal age is, these are the epilepsy syndrome that you will encounter. Some are benign, some are dangerous during the neonatal period. The dangerous ones are Ohtahara syndrome and the early myoclonic epilepsy, and how they are going to differentiate will be in another lecture, my last minute. And benign conditions we have to learn. Then the infancy, coming down to infancy, there are conditions, they are sometimes very dangerous. Now you understand the West syndrome. sometimes they are very bad prognosis. So therefore, it is not one condition. It's epilepsies what we are listing down here. Then the childhood absence epilepsies, the myoclonic and this Rolandic epilepsies, people call it benign. And when it goes to the other end of Lennox, the Landau-Kleffner syndrome, it is not that benign. You have the treatment spectrum, the Landau-Kleffner syndrome and the Rolandic epilepsy both have the same regions affected in the centrotemporal regions. And depending on the discharges, these differentiations take place. Then the epileptic encephalopathies is another topic altogether for us to discuss. And EEGs. Then the adolescents also, there are various epilepsies that listed down. So I think my basic intention of doing this lecture, while thanking to the organizers of this lecture, is to understand or to bring your thinking starting from just mere paroxysmal disorder, so you call it seizure disorder, coming up to a very comprehensive care plan which is tailor-made to the patient, and identifying their potentials and identifying their deficiencies also, and to optimize their care for the best interest of the child than the best interest of ourselves or the parents. So I think with this, this is how we bring the available evidence to support to develop a care plan. I hope that every one of you all will hereafter will not put just seizure disorder as your topic, and you will develop a comprehensive care plan for a child with epilepsy. Thank you very much for giving this opportunity.
Thank you, sir. Thank you for the excellent and very descriptive talk regarding childhood epilepsies. And let me remind you, this is our first lecture on childhood epilepsies, and we will be having a next one regarding more management options in next session within 2 months. So without further delay, we will move to the Q&A sessions. So we got a lot of questions regarding febrile seizures. So there are problems of cutoff 6 months to 6 years, and some saying 6 months to 5 years. So what is the exact value, sir?
Now there is no exact value. What happens is, what is febrile seizure? Febrile seizure is when a child is otherwise normal child, when you have usually generalized tonic or seizures only during fever, and then you call it a febrile seizure. So now in UK, there are 4 levels that clinicians are dealing with. The level 1, we can say like medical student just to get to know the epilepsy. Then the level 2 is like say registrar levels, like say you get to know the knowledge of how these activities are working on. And the level 3 is with your experienced consultants that with some experience on these conditions. And the level 4 is the guideline changing. Now this actually went up to a level 4 discussion when I was there. And this actually, there was a potential to classify febrile seizures as a reactive epilepsy or reflex epilepsy, because whether the fever is, and there are certain genetic conditions which are attached here with. Now, for the practical definition, Ilea, they say children between 6 months to 6 years are considered as febrile seizure. That is for the practical applications, because less than 6 months also you can have the so-called febrile seizures. But if you give that diagnosis, what will happen is the conditions, the meningitis and other dangerous condition which might come up in this age range may be neglected and put under this benign tag under febrile seizures. Then going beyond the 6 years also the same thing can happen. But in the real practice, we have to understand the principle behind. If they are getting seizures only by fever, you can call it a febrile seizure. Now the practice here is, if you get a febrile seizure less than 1 year, it's a case for you to investigate to see whether there is meningitis and other kind of infections have come in, or whether there's a metabolic or other conditions which may be giving rise to fever and the seizure. So that had to be verified. But when you are confident that there are family histories and then the child's otherwise normally developing, then you might, there are guidelines to and various parameters to say it is febrile seizures. Then going beyond the 6 years also, I have children who are 7 years, 8 years, only get febrile seizures only get seizures during fever. Now, usual practice is when they go beyond 6 years, you can call it febrile seizure with generalized seizure plus. You call it Jeff plus syndrome. And but if you only get seizures with fever, what you can do is you can still treat with febrile related events with medications only during fever to control the seizure. So this 6 months to 6 years is a basic guideline for us to make ourselves comfortable within that territory, but that doesn't mean that some meningitis can come as in the context of febrile seizure. At the same time, we might treat unnecessarily as meningitis when for a febrile seizure.
Next question again regarding febrile seizure. So what is a complex seizure? What is a complex seizure?
Complex febrile seizure.
Complex febrile seizure.
Yeah. The febrile seizures again classified into two, the simple febrile seizures and complex febrile seizures. How do you classify it? It's if the seizure comes in the first 24 hours and if it comes only once and during that age range, and then if you don't have any other post-ictal events, and then you might say it's a simple febrile seizure. But if you go beyond that, say if you get more than one seizure during one episode of fever, and if it comes after 24 hours, it goes into this complex febrile seizure for us to just to open our eyes and to see whether we are still in the febrile seizure range or not. But the whether it is the simple febrile seizures or the complex febrile seizures, according to NICE guidelines, are dealt in the same manner with regard to the management. But if it is tagged up with certain other elements to direct us for another unseen pathologies underneath this febrile seizure, then you have to deal with that situation rather than making it a simple or complex febrile seizure.
Next question regarding the EEG, sir. So can we have a normal EEG and can we have an abnormal EEG in a normal child?
Yeah, obviously, because the EEG, as I told you, it's a supportive investigation. It is not kind of confirmatory or pathognomonic unless certain other clinical features are tied up with that. So therefore, both ways it can happen. There can be normal people with abnormal EEGs, abnormal people with normal EEGs. And EEGs can be used to see two things from as a clinician, as far as the clinician. One thing is to see, as far as the epilepsy is concerned, EEGs have more other uses in other territories, but as far as epilepsy is concerned, whether it is purely epilepsy with the normal background, or whether the background also affected and you call it epileptic encephalopathy. So that verification can be made. So, and we are not treating epilepsy EEGs, we are treating patients. So when we are going to do, it had to be, as I told you, seizure will have to be verified. Then when you are going for the axis 3, then you build it up EEG and say electroclinical diagnosis. Without going through this process, just treating EEGs is not proper, and that is wrong. And sometimes the EEG is only a sample. Now, obviously, you have to understand, we can't, most of the time, other than these absence seizures and other things, we will not be able to capture a ictal event. We are doing interictal EEGs during. So with the interictal EEG, we are going to extrapolate what happens during ictal event. So, I mean, that is why the sensitivity of the EEGs are much lower. And at the same time, it is going to record the cortical and subcortical activity of the brain. But as you know, there are 5 layers on top of that, the scalp, SCALP up, and we are recording on the top. So because of that, the electric will get very milliamperes will come up to the top, and that also will be captured by a electrode, and that had to be amplified and generate it to a EEG. And at the same time, in the brain cortex, you know, there are sulci and gyri. Now, if the EEG foci is on the sulci, you might not pick it up. And then again, when you see the brain, there are certain territories at the base of the skull and certain posterior brains, you will not be able to place EEG leads to pick up that electrical activity. So therefore, there are certain limitations, and that is why the sensitivity of the EEGs are low. And at the same time, what happens is in the EEGs, It's unlike ECG, where the entire heart muscle and electrical activity work together in a synchronized manner. Here, of course, actually electric activity is in various directions, and you are getting only a summation of the electric activity during the interictal activity to extrapolate what happens at the ictal activity. So it's basically evidence-based or pattern recognition for us to get a help for us to ultimately conclude it under some kind of a syndrome or a epilepsy type.
Next question is, what is the place for neuroimaging in child with a seizure?
Neuroimaging, again, now I think we have to discuss under the management.
Yes.
Neuroimaging all depends that if we think about underlying cause, you have to go for, like say, child absence epilepsy. Usually you are not, unless we have any other neurological element, you are not going to do imaging. Benign Rolandic epilepsy, we are very confident. If you are very confident with benign Rolandic epilepsy and no other issues, you might not go for imaging. Febrile seizures, depending on the situation, you may or may not go for imaging. Then what type of imaging? Whether it is ultrasound, of course, at early ages, of course, not invasive, you can do that. But if you are going for CT, you are exposed into radiation. And if you are going for MRI, usually in children less than 5-6 years, we have to go for anesthesia. So because of that, you have invasive part as well. So therefore, you have to balance the risk versus benefit when you are going for imaging. And that will be to some extent decided by the syndrome and other activities and the cost axis 4, 3, 4, 5 plus if there are microcephalies and other things, we might think of that. But again, at some points it will be tailor-made to the patient concern.
Last question, sir. Even parents and doctors face a lot of difficulties to put a child on EEG monitoring. So is there any medication we can use for sedation while on the EEG? And is there any drugs which can affect the EEG monitoring?
Yeah, the drug, now, any of us, when we are sleeping, the hormone which is released by our brain is the melatonin. So melatonin is now commercially available. So if you give melatonin, they will go for natural sleep. And then you will not have any impact on the EEG. At the same time, sometimes patients get sleep deprived. So then they will go for natural sleep. Then there will be any impact. But usually in our practice, we use the chloral, which is the usually used medication. And that will have an impact on the EEG. There can be some fast activity and other things we are familiar with. And when we are taking an EEG, and luckily most of the EEG rooms are air conditioned. Because of that, this is sweat effect of the, because when you have the sweat, you have the sodium and other electrolytes coming up, and that can have impact on the leads. So air conditioned setup, that is basically eliminated. But as you said, these medications can have impact.
That will be all. So we have a lot of management questions came even in the chat and as well as after registration. So we will be dealt with these questions at the second lecture, and stay with us, and we will be doing it very soon, and we will let you know in usual pathways. So I'll hand over this session to Dr. Sachini to conclude the lecture. Thank you for joining with us.
Thank you very much, Dr. Hemal. And also thank you very much, Dr. Pardenia, for going through a very complex pediatric neurologic condition, which is occasionally misdiagnosed and also mistreated. This webinar will be, this session will be available for you on GMO Knowledge Academy channel. In few days will be sent in the chat box. Again, I thank for all the participants who participated today's webinar, and also we kindly ask you to send your feedbacks on behalf of the development of the webinars in future. Thank you very much.